Hello, this is Dr. Erica Pascal. Welcome to the Clinical Pharmacokinetics course. Thank you for watching my introductory brain shark video on vancomycin pharmacokinetics. The content included in this video is required material for the course. It is strongly recommended that you watch this video prior to class on August 14th. This video will introduce you to the basic principles regarding the antibiotic vancomycin and its pharmacokinetics and therapeutic monitoring. Watching this video ahead of class time will allow us to spend the majority of our class time focusing on vancomycin pharmacokinetic calculations. The content in this video, like I said before, is required material for the course and is fair game for exam questions. This slide lists all of the objectives for the full vancomycin pharmacokinetics lecture. During this introductory brain shark, we will focus on the first 4 objectives. After watching this brain shark, you should be able to describe pharmacokinetic principles that are relevant to vancomycin, list the adverse effects of vancomycin, identify and interpret appropriate vancomycin target trough levels, and develop a monitoring plan for a patient receiving vancomycin. The last 2 objectives will be covered in class on Monday, August 14th. To begin, we'll go over a little bit of introductory information about vancomycin. Vancomycin is a glycopeptide type antibiotic that only has gram-positive activity. It does not have any coverage of gram-negative organisms. Its spectrum of activity includes Staphylococcus species, including methicillin-resistant strains, Enterococcus species, particularly Enterococcus faecalis, and Streptococcus species. Vancomycin works by inhibiting synthesis of the bacterial cell wall, and is bactericidal for most organisms except Enterococcus, for which it is bacteriostatic. Remember that a bactericidal antibiotic kills the organism, whereas a bacteriostatic antibiotic simply impedes further growth. It's important to remember also that different types of antibiotics have different pharmacodynamic profiles. Vancomycin's is defined by the ratio of the 24-hour AUC to the MIC of the organism. The most optimal bacterial killing occurs when this ratio exceeds 400. Now let's review what the terms on this picture mean. AUC is the area under the curve. For vancomycin, we will want to know what the 24-hour AUC is. The MIC, or minimum inhibitory concentration, is the minimum concentration of an antibiotic that will inhibit visible growth of the organism over an overnight incubation period. Cmax is the maximum concentration of the antibiotic after administration of a dose. Like I said before, different antibiotics have different pharmacodynamic profiles. Some are time-dependent, meaning that they have optimal antibacterial activity when the concentration of the drug is above the MIC for a longer period of time. In this case, it doesn't really matter how high above the MIC the concentration gets. Others, like the aminoglycosides that we'll talk about next week, are concentration dependent. These work best when the concentration to MIC ratio is higher, so it's important to reach targeted Cmax or maximum concentration values with these drugs. Finally, vancomycin has the best antibacterial activity when the AUC 24 to MIC ratio exceeds 400. Vancomycin is not systemically absorbed when given orally, so only the intravenous form may be used for systemic infections. This drug has a wide distribution into body tissues and can even enter the cerebrospinal fluid fairly well in the setting of meningitis, when the meninges are inflamed. Vancomycin has a volume of distribution that varies widely, from 0.4 to 1 liter per kilogram. Vancomycin doesn't undergo much metabolism. It's primarily excreted via the kidneys as unchanged drug. Because of its dependency on the kidneys for elimination, its half-life varies widely depending on the individual patient's renal function. Like I said previously, vancomycin isn't absorbed after oral administration. The only time that you should consider recommending the use of oral vancomycin is for its local effect in the treatment of Clostridium difficile colitis. What we'll be focusing on today in this lecture is the intravenous use of vancomycin for systemic infections. The dosing of IV vancomycin is very patient-specific and can vary widely. For example, from only 500 milligrams every 48 hours for a small person with poor renal function, all the way up to 2,000 milligrams every 8 hours for a perhaps younger, larger patient with very good renal function. Typically, vancomycin is infused over several hours, with the maximum rate of administration not to exceed 1 gram per hour. Vancomycin is used in a number of different clinical scenarios for either empiric or targeted treatment of serious gram-positive infections. For empiric treatment, it's usually selected as the antimicrobial of choice if infection with MRSA is of concern. Some types of infections that vancomycin might be used for include those listed on the slide above, but recognize that this list isn't necessarily all-inclusive. There are several important adverse effects of vancomycin that you should be aware of. First are those that don't necessarily depend on the concentration of vancomycin in the patient's blood, but are more so related to the rate of infusion of the drug. Red man syndrome is characterized by pruritus, itching, and erythema over the face, neck, and trunk. This is usually caused by a too rapid infusion of vancomycin. Tachycardia, hypotension, and phlebitis, or irritation and pain at the site of the infusion, may also occur with a rapid infusion. These can be minimized by being sure that vancomycin isn't infused faster than 1 gram per hour. So for example, if the patient is to receive a 2-gram dose, this should be infused over a minimum of 2 hours. Nephrotoxicity and ototoxicity may also occur secondary to treatment with vancomycin, typically when vancomycin levels in the blood are elevated. Nephrotoxicity may be reversed with cessation of treatment in many scenarios. However, ototoxicity may be permanent. Both nephrotoxicity and ototoxicity may be more likely to occur if vancomycin is given in combination with other drugs that may cause these effects. I will now discuss how to monitor patients receiving vancomycin therapy. It's very important that you review the next several slides and have an understanding of goal trough levels and peak levels for vancomycin prior to class on Monday. Vancomycin therapy is typically monitored with the use of serum vancomycin levels. It's important to have an understanding of the different types of levels that can be obtained. A trough level is the lowest concentration that the drug reaches at steady state and is measured just before the administration of the next dose. The term trough level is synonymous with minimum steady state concentration and abbreviated CSS-min. The peak level is the highest concentration that a drug reaches at steady state and is measured just after the administration of a dose. The term peak level is synonymous with maximum steady state concentration, or the abbreviation CSS-max. Finally, a random level is the concentration of drug measured at any random point in time that is not specifically related to the timing of a dose. Although the best indicator of vancomycin's efficacy is the AUC to MIC ratio, it isn't practical, or in some cases possible, to measure the AUC in clinical practice. Because of this, a trough level is typically used as a surrogate. Typically, for most serious infections, a trough level of 15 to 20 milligrams per liter is recommended. These types of infections include pneumonia, sepsis, endocarditis, osteomyelitis, pyelonephritis, and meningitis. I like to remember this by thinking that any area of the body that might be tough to penetrate, such as the lungs or the bones or the central nervous system, you'll typically need a higher blood concentration of vancomycin in order to get effective drug concentrations at the site of infection. For less invasive infections, such as a simple cellulitis or an uncomplicated urinary tract infection, a trough level of 10 to 15 milligrams per liter may be considered appropriate and therapeutic. What you need to remember is that a trough level less than 10 is never okay. Levels less than 10 milligrams per liter have been associated with the development of resistance to vancomycin. You should never target a trough level of less than 10, and if you obtain a trough level on your patient that is less than 10 milligrams per liter, you should always adjust the dose to target a higher level. So when would you want to obtain a trough level? This should always be done when the drug is at steady state, so a minimum of 3 to 5 half-lives after initiation. For vancomycin, this timing usually correlates to around the 4th or 5th dose. You'll want to obtain this level within 30 minutes or less prior to the next scheduled dose. For patients on short-term therapy, measurement of one trough level is usually sufficient. However, if the patient is to remain on extended therapy for more than 1 week, it is recommended to obtain a weekly level. Vancomycin peak levels are typically not clinically relevant and not often used for routine monitoring. You do need to be familiar with what would be considered a normal or reasonable peak level because you will need to target this value in your pharmacokinetic calculations. In general, targeting a peak level between 30 and 40 milligrams per liter is reasonable. Truly though, the peak level doesn't matter. It's okay to have a relatively low peak value. For example, if you do your calculations and your estimated peak level turns out to be less than 30, this is still okay as long as your trough level is within the targeted range. Random vancomycin levels are best used to aid in monitoring patients receiving vancomycin who are on hemodialysis or peritoneal dialysis, or for those who have fluctuating renal function. These levels may be drawn at any time and don't need to be specifically timed before or after a dose. Besides vancomycin levels, what else should be monitored while the patient is receiving vancomycin therapy? Remember that vancomycin clearance is highly dependent on renal function, so a serum creatinine and BUN should always be routinely monitored during therapy. At minimum, these should be checked at baseline and then every 3 days during therapy. However, in the acutely or critically ill population, these are usually measured daily. Any increase of the serum creatinine of 0.5 or more, or an increase of 50% or more from the baseline, could indicate the presence of nephrotoxicity. As with all antibiotics, the patient's clinical response to treatment should also be monitored routinely. This includes trending things like the white blood cells, bands, and temperature. This concludes the introductory vancomycin pharmacokinetics video. I will see you in class on Monday.